discharge, duodenal atresia versus pyloric stenosis, burn percentage and management, percentage calculation, cholecystitis, cholelithiasis. That cholelithiasis leads to cholecystitis, right? And cholecystectomy indications. Hernia types and content, renal and uretary calculi treatment. Similarly, the intracranial hematoma and thoracosynthesis. So these are the the high-yield 10 topics which can be asked in the upcoming FMGE exam. So please, at the last moment, you can revise these 10 topics and then go to your exam, right? So let's start. First of all, we go with the nipple discharge. Okay, so in the nipple discharge, we make one mnemonic over here. BDS first batch. BDS first batch. Practice, right? Milky teeth. Okay, so BDS first year practice milky teeth. So it will be easy for you to remember in the exam. So let's see over here. B, bloody discharge, right? So if you see the bloody discharge or blood stain discharge, the most common cause is the duct papilloma. What is this one? Duct papilloma, right? So this is duct papilloma. Then BTS, serous discharge, right? If you have the serous discharge, then the most common cause is the fibrocystic disease. Okay, then you will see the the batch means black or green or paste like or the grumous discharge. Then you see this was the duct ectasia, right? Then you have the the practice means you have the pus, right? Purulent discharge means pus discharge. You will have the abscess, breast abscess. Okay, breast abscess. And then the milky means milk discharge, right? Then milky discharge, we have written over here the teeth, right? The milky teeth, milky discharge. You may have the prolactinoma, right? Or a patient may be the pregnant or lactating, right? And sometimes in the hypothyroidism as well, hypothyroidism. So please remember this one. Any color of nipple discharge, it can be with the duct ectasia. Okay. And initial investigation of choice for the nipple discharge, that is what? Ductalography. What is this one? That should be done with what? Ductography or ductalography. And in this ductography or ductalography, if there is an intraductal papilloma, you will see the small filling defect. Small filling defect will be visible if there is a duct papilloma. And if it is the cancers, then you will see the multiple filling defect. You will see multiple filling defect, right? And if it is the duct ectasia, you will see the dilated duct, right? It is due to the inflammation. The duct is dilated, right? Inflammation. Treatment of choice or the definitive diagnosis for the nipple discharge, that should be always the microdocectomy. What is this one? Microdocectomy. So hope you understand. Please remember this one. The mnemonic, what is this one? BDS first batch practice milky teeth. So remember this one, right? So these are the the options given there. Bloody nipple discharge, serous discharge, and you have the greenish or blackish discharge, right? Duct ectasia, this is fibrocystic disease. Here the duct papilloma. And what is the treatment? The duct papilloma, always go with the microdocectomy. If it is the duct ectasia, we say this is the Hatfield's operation. What is this called? Hatfield's operation. This is a question. All of these are questions in the exam. We are practicing the questions over here. And then let's go to the breast lump, right? So in case of breast lump, we have to see fibroadenoma, right? So fibroadenoma is the most common benign tumor of the female breast. It's the most common benign tumor of female breast. Okay, so remember this one. And it has the focal sensitivity to this estrogen. It has the focal sensitivity to the estrogen, right? and it is also called the breast mouse. What is this called? It is also known as, what is this one? Breast mouse. BREST, breast mouse. It is also known as what? The breast mouse. And it is painless mobile lump. What is this one? It is also known as breast lump. It is most common, right, benign tumor of the female breast. Breast lump, it is mobile, that's why called what? The breast mouse. What is this called? Breast mouse. Is that okay? And it is painless, right? So you should understand this one. Investigation of choice is what? F and AC. You can do the F and AC, and in the F and AC you will see the antler horn appearance. What do you see? Antler horn appearance, right? And you may see the popcorn calcification in the mammography. What will you see? Popcorn means it looks like this, right? So you will see something over here. That's the popcorn calcification. This will be seen in the mammography. Hope you understand, right? And what is the treatment? The treatment of choice is this one. No need any treatment, right? You don't need any treatment. Sometimes if it is bothering you, then you can go for the excisional biopsy. Excisional biopsy, right? So this is the treatment of choice. Excisional biopsy means you will hold the mass. After removing the mass, you can go for the the pathological investigation if it is suspicious or something else, right? Then we go to the breast cyst. Breast cyst is one more point. Fibroadenoma is very common in the young age, 20 to 30 years, right? Breast cyst is common in the old age. It is common in the old age, right? And it is multiple. And usually present in the both sides, okay? Both sides. Actually, why this breast cyst appears in the old age? Because during the old age, what happens? The stroma and the glandular tissues both undergoes involution, right? So this disintegrated, this involution, they do not match. The stroma involution and then the glandular tissues involution, they involute, they decrease in their size in two different speeds. That's why the cyst formation occurs, right? So the investigation of choice is aspiration and or USC. Aspiration of cyst and or you can do the USC, right? So this is the investigation of choice question in the exam, right? And the treatment is you can do the aspiration if it is a single cyst, and during the if there is multiple cyst or there is blood staining during the aspiration, then you have to go for what? The core biopsy or excision. You should go for core biopsy or excision, right? So if you have the blood stain or multiple cyst, go for the core biopsy or excision. Otherwise you can go for what? Simply the aspiration of the fluid from the cyst, right? Then we go to the duct papilloma. Duct papilloma actually means what? It's a polyp-like growth in the lactiferous duct. Lactiferous duct, right? So this is a duct papilloma, and it is single, right? Around the areola, it is single, and it is usually around the areola. Is that okay? And then the size is usually less than 1 centimeter. Less than 1 centimeter size, and this is the most common cause of what? Nipple discharge. Nipple bloody discharge. Nipple bloody discharge. We discussed already, right? So this is a very, very important question in the exam. And most common symptom is bloody nipple discharge. Most common symptom is bloody nipple discharge. Remember this one. Investigation of choice for the duct papilloma is the ductography. What is this one? Ductography. Wherever there is a duct, you should go for what? Ductography. Treatment of choice is the microductectomy. We discussed already, right? Microductectomy. That means you just cut the involved ducts, right? And let's go to the ductectasia. Ductectasia means we said already, it's a dilation. What is this one? is a dilation of the lactiferous duct. Lactiferous duct. Why it is dilated? It is dilated because of the inflammation. That's why it is also called what? Periductal mastitis. This is also called what? Periductal mastitis. Most common symptom is the nipple discharge. It is what? Nipple discharge. And this nipple discharge can be of any color, depending on the stages of this dilation, on which stage it is, how many days, how many months it passes. Depending on that, the color changes, right? So maybe black, maybe green, or maybe paste-like, right? The investigation of choice, it is also involving what? The duct. So the investigation of choice is what? The ductography. That is ductography, right? And the treatment of choice is what? We already said Hadfield's operation. That means microdocectomy. Just cut and remove those involved or dilated ducts, right? So you can see in the picture also, right? So how is this, right? Breast abscess. In the breast abscess, the most common cause you have to understand is the Staph aureus. What is this one? Staph aureus, Staph aureus, and it is most commonly due to the the breastfeeding, because while feeding the baby, sometimes they may injure the nipples. So from that, the baby's oral cavity, the Staph aureus will transmit it, right? And it produces what? The focal abscess. Is that okay? Localized and focal abscess. But sometimes the streptococcus may involve. If the streptococcus is involved, then the the abscess becomes diffuse and it becomes superficial as well. So what is the diagnosis for this one? Diagnosis usually is clinical diagnosis, or sometimes we can do the USC as well, right, if it is confusing. The treatment of choice is what? We have to go for the incision and drainage if it is abscess found. If it is at the earlier stage of the abscess, or if the abscess size is smaller, then we can go for what? Antibiotics. In the antibiotics, our choice is what? The dicloxacillin or cloxacillin. Dicloxacillin or cloxacillin. Usually we give this for how many days? 14 days. Hope you understand, right? And if we have to go for the IND, we can make the incisions like circumareolar incision, or we can make the radiate incision like this, right? So this radiate incision we make in parallel to what? The Langer's line. What is this line called? Langer's line. Is that okay? So we have to understand like this. We should not cut like this breast. If we cut like this, we will cut the the lactiferous duct. So that we should be very much careful. You can see the picture of the abscess, breast abscess over here. Breast cancers. Now let's go to the breast cancer risk factors. Remember, breast cancer risk factors, combined pills, right? This is the risk for breast cancer. This is a question in the exam, okay? Combined pill, that means estrogen plus progesterone. But if it is only estrogen pills, then this is no risk to breast cancer. It's a question in the exam. Smoking and OCP is not considered as the risk factor, not considered the risk factor. Okay, so please remember this one. And prolonged breastfeeding is considered as the protective for breast cancer, right? So that is better to feed the baby. Then let's go to the the breast cancer associated genes. That is what BRCA1 and BRCA2 gene. BRCA1 is present in we have written over here, right? BRCA1 is present in chromosome number 17. BRCA2 is present over here in chromosome number 13. So remember, this is a question in the exam, right? So BRCA1, BRCA2 both produces the invasive ductal carcinoma. Invasive ductal carcinoma both produces bilateral. Both produces what? Bilateral. Hope you understand. Another point over here is that, see, BRCA1, 1 is odd number, so that we can say 1 and 3 is odd, right? So that it is triple negative. It is triple negative breast cancer. Triple negative breast cancer means what? It is a progesterone receptor negative, estrogen receptor negative, and HER2/NEU, that is also negative, right? So that it is triple negative breast cancer. and BRCA2, right? BRCA2 has 2, so 2 means it is double positive. It is double positive. Double positive means estrogen receptor and progesterone receptor positive, right? So this is a double positive, and both occurs in the early age. Both occurs in the early age, and BRCA2 is associated with melanoma as well. It is associated with melanoma. So remember these many points for the exam, right? So BRCA1, 1 and 3 is odd, so that 1 and 3 is 3 odd, means it's triple negative, right? And BRCA2 there is 2 means double positive, that is ER positive and PR positive. Risk assessment model for the breast cancer, we use the model for what? The model is a Gale model and Claus model. What we use? What is this one model? Gale and Claus model for the risk assessment. They can ask you a question in the exam. Which model do we use for the risk assessment of the breast cancer, right? So this is Claus and Gale model. The details we will discuss in the normal lecture classes, but here we are doing the preparation for the exam only. Now let's go to the ductal carcinoma in situ. Ductal carcinoma in situ means what? It's a papillary growth. Papillary growth within the duct, right? It is not metastasized, so that is a ductal papilloma in situ, right? And usually it involves the unilateral breast. It involves what? Unilateral breast. And we have the histological types. For the histological type, we have the low grade and then the high grade, right? So for the low grade of the histological type, we can remember as cribriform, papillary and micropapillary. What is this one? Cribriform, papillary and micropapillary, right? So how can you remember this one? This one we can remember as the cyclic LMP. Okay, so that remember as CLMP for the mnemonics. These are the low grade ductal carcinoma in situ. So what are those low grade ductal carcinoma in situ? C means what? Cribriform. L means low grade. M means micropapillary. P means papillary, right? So these are the low grade breast cancers. They will be asked you in the exam, right? And then the high grade is we have the the solid and comatocarcinoma. What is this one? Solid and comatocarcinoma, right? So you can remember this as solid and comatocarcinoma as HSC board, right? Higher secondary board, right? So you can remember this one as higher secondary board, HSC board as the high grade, right? And this classification of low grade or high grade is done on the basis of what? Nucleus and the status of the necrosis. Necrosis, at which level of the necrosis present or what kind of nucleus is present. On that basis this is classified. Okay, diagnosis, let's go for the diagnosis. Then we do the mammographic mammography we do, and we see the calcifications. Diagnosis is what? Diagnosis is mammography we can do. And what's the treatment? For the treatment, if it is non-palpable DCIS, then we do the needle localization first we do. If it is low grade less than 0.5 centimeter, we go for the lumpectomy. What is this one? Lumpectomy, we cut the lump. And if it is the DCIS with the limited disease, then we go for the lumpectomy with radiotherapy. Lumpectomy plus radiotherapy, RT, right? If DCIS more than 1 centimeter or more than 1 quadrant involved, then we should go for what? Mastectomy. Usually we go for what? Modified radical mastectomy, MRM. Hope you understand, right? So this is ductal carcinoma in situ. Remember, it's a papillary growth, and it involves only the lumen, right? And histologically we divide into two types, low grade or high grade, and according to what? The nucleus, the pattern of nucleus, and then the pattern of necrosis present within the mass, right? So we divide this into low grade or high grade. Low grade we have three types, that is cribriform, papillary and micropapillary. We already discussed, that is CLMP, cyclic LMP as a mnemonic, right? And high grade we remember as solid and comatocarcinoma, right? And this we can remember as the HSC, higher secondary board, right? Diagnosis is what do we do? It's a mammography we can do, and we see the calcifications, right? And treatment is, if it is non-palpable TCIS, just go for the needle localization first, right? After that, you can cut and remove the the lump. And if it is low grade, less than 0.5 centimeter, then you can go for the lumpectomy, right? And DCIS with limited disease, then lumpectomy is radiotherapy you have to do. If it is involving more quadrant and if the size is more than 4 centimeter, then you have to go for what? Modified radical mastectomy, right? Let's go to the lobular carcinoma. So lobular carcinoma, it develops, right? It grows in the terminal duct. It grows in the terminal duct in the breast lobule, right? And it is, yes, it involves the bilateral. It involves the bilateral breast. Yeah, it's written over here, bilateral breast and terminal duct. Histologically, it seems like a Indian file pattern. Like we arrange the files and then we keep the files like this, right? With these layers. So this is a, histologically it appears as an Indian file pattern. Remember this one? Indian file pattern. Question in the exam, okay? They will mention this point in the question and they will ask you, what is this one? What's your diagnosis, right? Then you have to say it's a lobular carcinoma. And what is the symptoms? It's a breast mass with ill-defined margin. Symptoms is breast mass. This is the most common symptom. Diagnosis, we can do what? We can see the mammography, then we can see surrounding calcification, right? So we see this one. And what is the treatment? Treatment is always with the prophylactic bilateral mastectomy. We do what? Prophylactic bilateral mastectomy. Please remember this one. Question in the exam. In one side, if there is a lobular carcinoma, we have to go for the bilateral mastectomy because it may involve both the lobes, both the breast. You can see over here, right? So it is involving one lobe, the terminal duct. Do you understand? This is a duct, and the terminal duct it is involving only one lobe, right? So you should understand this one. This is a lobular carcinoma. Invasive breast cancer. Invasive breast cancer is the most common cancer in the women worldwide, right? And most malignant type of the invasive cancer, the invasive breast cancer is what? The inflammatory breast cancer. What is this one? Inflammatory type is most malignant. And what is the most common type of invasive breast cancer? One is most malignant type of invasive breast cancer, that is inflammatory type, and the most malignant, and the most common type of the invasive breast cancer, that is what? That is the invasive ductal type. That is what? Invasive ductal carcinoma. Invasive ductal carcinoma, that is also with serous type, SCHIRROUS, serous type, right? And least common type is what? The papillary type. Least common type is papillary type. So please remember, these are all are the questions in the exam. And what is the best prognosis? Which type has the best prognosis? The best prognosis is with the tubular type. What is this one? Tubular type has the best prognosis. Is that okay? So best prognosis tubular type, the least common type papillary type, most common type is invasive ductal carcinoma, and ductal type you can say, right? And most malignant type is the inflammatory type, right? So you should remember like this. Best prognosis you understand. And what is the most common site? The most common site, I forgot to put the the picture over here. We divide the breast into 4 quadrants like this, right? So for example, this is our sternum on this side. So this is my upper inner quadrant, this is my lower inner quadrant, this is my outer lower quadrant, and this is my outer upper quadrant, right? So outer upper quadrant, this is the most common site, and the lower inner quadrant, this is the least common site. So please remember, this is the question in the exam. Outer so upper, most common site is what? Outer upper quadrant. Least common site is what? Lower inner quadrant, right? And this is also, they can ask you, usually left breast more than the right breast. So I hope you understand, right? And most common site of the metastasis of the breast cancer, that is the bone, right? So this is what? The bone usually. And in the bone also you have to understand it goes to lumbar vertebra. Which vertebra? Lumbar vertebra. Lumbar vertebra, right? So this is the most common bone for the metastasis. And then it may go to the femur, right? It may go to the femur, and then it may go to the thoracic vertebra. And most common death, cause of death in case of breast cancer, that is what? The malignant pleural effusion. What is this one? Malignant pleural effusion. Malignant pleural effusion because of the metastasis. Hope you understand, right? So invasive ductal carcinoma, you understand. What is the symptoms? Symptoms is you can see the powdery orange or nipple retraction or dimpling. Powdery orange means you can see it is it looks like this one. It is because of the superficial lymphatic involved. Superficial lymphatic involvement, right? Involvement. Superficial lymphatic involvement. Then it produces what? The powdery orange appearance. Nipple retraction, it is because involvement of the subareolar or subnipple duct. Subnipple duct, so that the nipple will be retracted like this. And you can see like this, you know, the dimpling. This dimpling is because of the involvement of the ligament of Cooper. Cooper ligament involvement. So it produces the dimpling. These are the questions in the exam, okay? What produces the powdery orange? What produces the nipple retraction? What produces the dimpling, right? So these are the questions. In evaluation, you can do the triple assessment. What are those triple assessment? That is what? Physical examination you can do, self-assessment. Then you can go for the imaging studies, right? Imaging studies. In the imaging studies, either you do USC or you do the mammogram, right? And the third one, you can do the tissue sampling. In the tissue sampling, you can do either FNAC or true cut biopsy. So these three things you can do. That is called what? Triple assessment. And first investigation of choice is the first investigation of choice is usually the, let's go, right? So the first investigation of choice is usually mammography or USC, okay? That is mammography or USC. If the age is less than 35 years, we go with the USC. If the age is more than 35 years, we go with the mammography, because less than 35 years, there is a breast tissues, right? We have the glandular tissues, so that the mammography cannot make a good image for those, so that we go with the USC. And in the mammography, more than 35 years, usually mammography use how much dose of the radiation. Sometimes they can ask you in the exam, 0.1 CGY, right? Guided, centi-guided. It used this much dose of the radiation, the X-rays, right? The normal X-ray is 25% of the normal X-ray is this one, right? So this is a question in the exam. And in the mammography, we do the two views. One view we do is the MLO, that is mediolateral occipital view. Another one we do is what? The CC view, that is craniocaudal view. Two views we do, and then we see this one, right? So this is the first investigation of choice. And what is the best investigation of choice? That is the biopsy. That is biopsy always, right? And BIRAT system we use sometimes also for the assessment, right? BIRAT means what? Breast imaging, reporting and data system. Sometimes they can ask you the full form: breast imaging, reporting and data system. Hope you understand, right? MRI sometimes we can do. The MRI is used for the staging, and it is used for the lobular carcinoma as well. It is also used for what? The lobular carcinoma, right? It is also used for the lobular carcinoma. It is used for the it is used for the staging of the breast cancers, and it is also used for the younger women who are at the risk of the breast cancer, right? Younger women who are at the risk, right? Who are at the risk means, for example, those who have the the history of breast cancer in their family, right? So like these things in the close relatives. And similarly with the breast implant, who are with the breast implant. So this is also the question in the exam, right? So what are the indications of the MRI in case of breast, right? Breast cancers. And what are the mammographic features do we see, right? If it is the benign, if it is the benign mass, then what do we see is that there will be the macro calcification. What is this one? Macro calcification. Macro calcification means the calcification size will be more than 0.5 millimeter, right? And you will see the thin halo around it, right? Thin halo, and it is smooth. It is smooth. Then we call this is what the benign calcification. Is that okay? And sometimes if it is malignant, what do we see is that the calcification, this will be like this. That means what? The stellate, star-like, or maybe the comet tail-like appearance. What is this one? Comet tail-like appearance. Comet tail-like appearance, right? And the size will be micro. What is this one? Micro calcification. That means less than 0.5 millimeter. Then we say this is what the malignant calcification, right? So that these are the features, mammographic features of the malignant, and then the benign calcifications. These questions can be asked in the exam, right? And some the pattern of calcifications we can see over here, right? So if it is the microcalcification branching or the punctate, then it is a carcinoma. If it is popcorn calcification, this is the fibroadenoma, question in the exam. If it is powdery calcification, then this is the cystic, fibrocystic disease. And if it is the curvilinear calcification, then this is called what? The fat necrosis. It's not the fat, it's a fat necrosis, right? So you can see the examples over here: microcalcification, popcorn calcification, powdery calcification, curvilinear calcifications, right? So remember, curvilinear, then fat necrosis, right? If it is the powdery, then fibrocystic disease. If it is the popcorn, then it's a fibroadenoma. If it is microcalcification with branching or punctate like the comet tails we just discussed, that is what? The carcinoma. AJCC staging of the breast cancers, we just see the among this T and M, we just see the T staging over here, right? So in this T staging, T1 means if the size of the the cancer is less or equal to 2 centimeter. If it is less or equal to 2 centimeter, then we say this is T1 stage, right? And if it becomes 2 centimeter to less or equal to 5 centimeter, this is a T2 stage. And if it is more than 5 centimeter, we say this is what? The T3 stage. Remember, these are the questions for exam, right? And for the treatment, let's go with the treatment. That is what? The stage 1, 2A and 2B. If these three stages we have, then we go with what? The mastectomy. Plus we will assess the axillary lymph nodes assessment. Is that okay? And if it is the stage 3A, 3B and 3C, look at here, all the stages with 3, right? A, B, C, all these 3 stages, we go with what? The chemotherapy plus modified radical mastectomy plus radiotherapy, right? So we do this 3 things. And if it is the distance metastasis, that means the stage 4 disease, then we go with what? The hormonal therapy. That is hormonal therapy. Please remember this one. And in the chemotherapy, sometimes we use, what is this one for the chemotherapy? If patient has HR positive, hormone receptor positive, and if it is more than 1 centimeter size cancer, then we use what? The tamoxifen, right? And if the patient has the HER2 and EU positive, right, then we go with what? The trastuzumab. So please remember, these are the the questions in the exam, right? So if the patient has a hormone positive means what? Estrogen, progesterone positive, right? Estrogen, progesterone positive. Estrogen, progesterone positive means double positive, right? Double positive means BRCA2 that we discussed already, right? And then if the patient is HER2 and EU positive, we go with what? The trastuzumab. So remember, these are the questions in the exam. And prognosis in breast cancers, let's see. The prognosis indicators in breast cancer, that is what? Number 1, the stage, okay? In which stage of the breast cancer it is? Stage 1, stage 2A, 2A, 2B, 3A, 3B, 3C, or stage 4, which stage breast cancer it is. According to that, the prognosis differs, right? So stage has the more impact in the prognosis than the axillary lymph node involvement. Sometimes they can ask you the statement type of questions. Which of the following best describes the prognosis of the breast cancer, right? Then you have to choose the best one is what? Stage of the breast cancer. It's not the axillary lymph node involvement. Then hormone receptor status, hormone receptor status, okay, another point. And similarly, if the patient has the estrogen receptor positive, progesterone receptor positive, and HER and HER2 and EU, right, negative, it has the best prognosis, right? If we have the ER and PR positive but HER2 and EU negative, it has the best prognosis, and it is the most common type according to the receptor status. Is that okay? It's the most common type of breast cancer. And if the patient has opposite to this one means the ER and PR is negative, and we have the HER2 and EU positive, then it has the worst prognosis, right? Worst prognosis. Remember, HER is a woman, right? Breast cancer is common in the women, right? So that if HER positive, women positive, then it has what? The worst prognosis. If C is negative, that means HER negative, then this is what? Good prognosis, best prognosis, remember. Now let's go to the thyroid gland. Look at here, thyroid gland is the the endocrine gland. It's present within the neck, right? So you should remember. And this is our trachea. So this, our thyroid gland, is present in between these rings of the trachea, right? So this is between the second to fourth tracheal ring, second to fourth tracheal rings, right, in the midline, right? And it is within the vertebral level of C5 to T1, vertebral level of C5 to T1, and weight of the thyroid gland is about 20 to 25 gram. Remember, this is the anatomy, right? And it is developed from the foramen cecum at the base of the tongue, and then it descends down by the time, right? So that this is the site of the formation. And the parafollicular cells, they are developed from the fourth pharyngeal pouch. So we have the thyroid gland. Thyroid gland has the follicular cells and then the parafollicular cells, right? So these follicular cells, they are developed from what? Foramen cecum, base of the tongue, And we have the parafollicular cells, C cells. These parafollicular cells or C cells, they are developed from what? Fourth pharyngeal pouch. So remember this one. These are the questions in the exam, right? And let's see the thyroid carcinoma, right? In the thyroid carcinoma, most common malignancy of the endocrine gland is what? Most common malignancy of the endocrine system, that is the thyroid cancer. So thyroid carcinoma or thyroid cancer is the most common malignancy of the endocrine system. And what are the types of the thyroid cancers? We have the papillary type. Let's see something of the papillary type. In the papillary type, what happens? It's the least malignant. It is least malignant, right? And you can say this is the most common thyroid cancer seen after radiation, right? Patient who is under radiation, and it shows the dystrophic calcification, right? And similarly, it has the Sammoma bodies, PSAMMOMA, Sammoma bodies, right? I will discuss the DDs of Sammoma bodies. This kind of, the whole of the cells will be same, and it shows the orphan Ni-I's nucleus. Sammoma bodies with orphan Ni-I nucleus, right? So remember this one. And very commonly asked questions from this one is the most common route of metastasis. That is what? Lymphatic route of metastasis. So the most common route of metastasis for the papillary carcinoma of the thyroid is what? The lymphatic metastasis. So please remember this one, right? So how will you remember this one? This is as IPL, right? So IPL, papillary carcinoma with the lymphatic metastasis and cause the invasion, right? So IPL, remember as IPL. So this you should remember. And In this condition, patient is usually euthyroid. Euthyroid means thyroid hormone level neither increase nor decrease. Hope you understand, right? And then the tumor marker in this is the thyroglobulin. What is this one? Thyroglobulin is the tumor marker in this case, right? So please remember this one. And the another point you should remember over here is that the papillary is the most common type of the thyroid cancer. This is what papillary type is the most common type of the thyroid cancer. This is the most common type of the thyroid cancer. Let's go to the follicular type. Follicular type, it occurs in the multinodular goiters. Multinodular goiter. This is a question in the exam. Okay, so it occurs in the multinodular goiters, and it has the hematogenous metastasis. Hematogenous. So how will you remember this one? FSH. Is that okay? Hematogenous metastasis to follicular thyroid cancer, right? So please remember, this is a question in the exam. And the most common site of the metastasis is what? The bone. It goes to the bone. Follicular cancer, it most commonly metastasizes to the bones. And the papillary is the most common site for the papillary is the lungs. Remember, okay? So papillary thyroid cancer most commonly metastasizes to the lungs, and follicular most commonly metastasizes to the bones. And remember, most common route is hematogenous spread for the follicular cancer. This please remember, question in the exam. Okay, yeah. And another very important point is that follicular cancers, it produces the thyrotoxicosis. What is this one? Thyrotoxicosis. So please remember, these are the questions in the exam. And yes, there is one subtype that is called Harthal cell type. They will ask you in the exam, Harthal cell type of thyroid carcinoma is which type of thyroid carcinoma? So please remember this one. Another type is what? The anaplastic type. Anaplastic type is the most malignant type. It is what? Most malignant type. Most malignant type is the anaplastic type, and it has a direct invasion. Direct invasion. This is the route of metastasis. Direct invasion is the route of metastasis. That means, how will you remember this one? Autosomal dominant, AT, okay? That means anaplastic thyroid cancer has a direct invasion. This type of metastasis it has, and most common site metastasis is to the lungs. Most commonly it metastasizes to the lungs. So please remember this one. And it is 100% lethal. It is 100% lethal. So it is a very dangerous, the subtype, and it will show the osteoclast like multinucleate giant cells. So what will you show? It will show the osteoclast like this multinucleated giant cells. Okay, so this is the hallmark of this anaplastic type. So hope you remember, right? And medullary carcinoma. Medullary carcinoma means it is the C cell cancer, right? Parafollicular cell cancers, right? So that parafollicular cell, it is associated with the MEN syndrome. It is associated with what? MEN syndrome. MEN syndrome. We will discuss about the MEN syndrome after some time, right? And it is metastasized through the lymphatics, right? So it also has the lymphatics metastasis, and commonly it goes to the liver. It goes to the liver. So see, it's quite different, right? We have the what is this one? The papillary also lymphatic metastasis, but it goes to the lungs. But we have this one, the medullary thyroid carcinoma. It also metastasizes to the lymphatics, but it goes to the liver. So please remember this one. And another is what? Another important point. Yes, it releases the calcitonin. So the calcitonin is the tumor marker. That is tumor marker. So tumor marker is what? The calcitonin in this case. So remember. And lymphoma, you can discuss Hodgkin, non-Hodgkin lymphoma. This is not much important for this exam. And metastasis, you can see over here, the most common cancer with metastasized to the thyroid gland, right? So this is what? This is what? The breast cancer. Breast cancer. So the most common cancer which metastasized to the the thyroid gland. That means the most common secondaries to the thyroid gland is what? The breast cancer. So remember, this is a question in the exam, right? And recently in the abelian lobes, they have added as the renal cell carcinoma. I don't know how will they ask you the question. Let's see the mean syndrome. In the mean syndrome, we divide the mean syndrome into mean type 1, 2A, 2B, and mean type 4. Right? So remember, ME and mean. Men are usually dominant, autodominant. That's why mean syndrome is autosomal dominant disorder. This is autosomal dominant disorder, right? And then let's see over here, MEN1. So MEN1 has 3P. MEN2A has 2PM, right? MEN2B has 2 MPs, right? So 2 MPs, remember like this. So MEN3P, 3P means what? Pituitary, and you have the parathyroid, and you have the pancreatic, okay? Pituitary adenoma, parathyroid hyperplasia, and then the pancreatic islet cell cancer. This pancreatic islet cell tumor, we can say, this tumor can be the insulinoma, or maybe the Zollinger-Ellison syndrome, right? So this is the 3 P's. That is what the 3 P's of this is the 3 P's of your what the MEN type 1. And remember one more thing, MEN type 1, right? So MEN type 1, remember, right? So this is MEN type 1 and this is present in chromosome number 11q, chromosome number 11q. So please remember, these all are the questions. And it is also called the Wermer's syndrome. What is this called? Wermer's syndrome. This is MEN type 1. Let's go to the MEN type 2. MEN type 2 has, we said already, 2 PM, right? So what is this 2 PM? 2 PM means that it continues with the parathyroid, right? And another P is, it goes to the pheochromocytoma. What is this one? Pheochromocytoma. And then M for it goes to the medullary thyroid carcinoma, right? So this is what 2 PM, right? So please remember this one. And it is present in the chromosome number it is present in chromosome number 11, chromosome number 10q, and it contains the menin1 gene. Is that okay? That means mutation in this gene. This is the MEN2A, that is 2 PM. Let's go with the MEN2B. 2A we did, 2B. 2B is what? 2 MP, right? So that is, what is this 2 MP? 2 MP means, you can see over here, that is the medullary carcinoma thyroid, continue. Medullary carcinoma thyroid, 1M. Another M is what? Mucosal. You have the, what is this one? Mucosal neuroma. That is mucosal neuroma, or Marfanoid habitus. That is M. And that is 2M. Then we go for P. That P is what? The for the P is that pheochromocytoma. Continue, pheochromocytoma, right? And the chromosome number here also, the chromosome number 10q. And the gene is what? MENIN, menin2 gene. So remember like this, right? That is mean 2B. And then we go to the mean 4. That MEN4 is a little different entity. This is present in chromosome number 12p, right? The gene for this one, and it produces the adrenal tumor, renal tumor, and reproductive organ tumor. What is this one? Adrenal plus renal plus reproductive organ tumor, right? So this is our what? MEN type 4. So MEN type 1, 2A, 2B, and type 4, right? So sometimes this type 2B is also called MEN type 3. That is MEN type 3. That's why we make it MEN type 4. Hope you understand, right? So these are the MEN syndrome, and please remember this for the exams, right? So I think you can remember, for the MEN1 you have the 11q, then this 2 has the 10q, and then the another one is 12q, right? So 10, 11, 12 like this, and you have the 3p, 2pm, 2mp, and then the type 4 has a little bit different types of entity over here, right? So please remember this one for the exam. Let's go to the thyroid surgery. Right? In this thyroid surgery, we have the total thyroidectomy. What is total thyroidectomy? We remove all the thyroid gland. all the thyroid gland we remove. In case of total thyroidectomy, you can see over here, we remove all the thyroid gland, but we do not touch the recurrent laryngeal nerve. We do not touch what? Recurrent laryngeal nerve. And then we have the near total thyroidectomy. In the near total thyroidectomy, what do? Is that we remove almost all the tissues. In case of what is this one, near total thyroidectomy, where do we have? Yes, we remove almost all the tissues, but we leave nearly 1 gram of the thyroid tissues. Rest of others we all remove. In this 1 gram, usually we leave in the posterior capsule. Posterior capsule. This is called what? The near total thyroidectomy. Another we have here the subtotal thyroidectomy. In case of subtotal thyroidectomy, we remove all the thyroid, but we leave about 5 to 6 gram of the thyroid. The total weight is 20 to 25 gram. We leave 5 to 6 gram. That is called what? The subtotal thyroidectomy. And we have the lobectomy or isthmectomy. You know that lobectomy means we remove one lobe of the thyroid like this, right? Or hemithyroidectomy also we can say. And isthmectomy means what? We just cut the isthmus of the thyroid. You can see over here, this much part is removed, right? So this is the isthmusectomy. So that according to our requirements, we do the different types of thyroidectomy. So please remember this one. And here, what are the complications of the thyroid surgery? The complication is what? Slipping of the ligature. Slipping ligature. The slipping ligature, it produces sometimes the reactionary hemorrhage, right? So this slipping ligature, usually this question they can ask you in the exam, right? The patient, he has the thyroid surgery maybe the 4 hours or 5 hours ago, and then right now the patient has the neck swelling and patient is feeling the asphyxia or difficulty in breathing. What is the diagnosis? That means the patient has the slippage of the ligature and then patient having rebleeding over there, right? So if the patient having the rebleeding over there, they will ask you another question over there, what is your immediate the management? Then the immediate management should be, you have to take the patient to the OT again and you have to reopen that, right? So open, you have to evacuate the hematoma and then again you have to resuture it, right? So please remember this one. This is the complication. Another complication is that they may cause the nerve injury, and the most common nerve injury is that what? The recurrent laryngeal nerve. This is the most common nerve. And then the second nerve they may injure is that the external laryngeal nerve. External laryngeal nerve. External laryngeal nerve, right? So these are the complications of the thyroid surgery, please remember. And in the long term, of course, yes, they will have the hypothyroidism as well, right? So they have to take the long term the thyroid supplements. So these are the questions they may ask you in the exam as a complication of the thyroid surgery. Now let's go to the thyroid nodules. In the thyroid nodules, the most common solitary thyroid nodule, most common solitary thyroid nodule is that what? The benign colloid nodule. What is this one? Colloid nodule, that is benign, right? And second most common is the follicular adenoma. Second most common is what? Second most common is follicular adenoma. Hope you understand, right? So these are the questions. And what is the investigation? That is USC. USC is the gold standard investigation of choice, and they can ask you the first choice also. USC is gold standard also. The USC is the first investigation of choice also of the thyroid nodules. Hope you understand, right? And some DDs of the sum bodies they can ask you in the exam. So please remember as the DDs over here, PPSSMM, right? So what are those PPSSMM? P for papillary thyroid cancer, P for prolactinoma, S for serous ovarian cancer, S for somatostatinoma, M for meningioma, M for mesothelioma. So please remember sometimes also the appendiceal tumor as well, right? So it also comes with the sum bodies, and in the sum bodies they can give you the question like this, right? The whole light pattern present, right? So remember, let's see the neck swelling DTs. In the neck swelling DTs, we use the rule of 7, right? Rule of 7 is what? If it is present for the 7 days, if the swelling is present for 7 days, right, it is inflammatory, right? If it is present for the 7 month, it may be neoplastic. It may be neoplastic. If it is present for the 7 years, then we say this is what? The congenital. congenital. Hope you understand, right? And we have this some mnemonic for the cystic neck swelling, that is ABCD. What are those ABCDs for the cystic neck swelling? Anterior to the SCM. SCM means sternocleidomastoid muscle, right? We have the sternocleidomastoid muscle going like this. Yes, this is our clavicle, and we have the sternum over here. Yes, so we have the sternocleidomastoid muscle. So you can remember this is the midline, right? If something is there within the midline swelling, right? This is what? This is a thyroglossal cyst. What is this one? Thyroglossal cyst. If something is present which is medial to the sternocleidomastoid muscle, then this is a branchial cyst. What is this one? Branchial cyst, right? This is what? The branchial cyst. Then if you have the this mass which is present lateral to the sternocleidomastoid muscle, this is what? The cystic hygroma. What is this one? Cystic hygroma. Hope you understand, right? So please remember, in the midline, that is what? Thyroglossal cyst. If it is lateral but medial to the sternocleidomastoid muscle, this is what? The branchial cyst. This is what? Branchial cyst. And if it is lateral to the sternocleidomastoid muscle, then this is what? The cystic hygroma. So please remember like this. So you understand already. Anterior to SCM is what? Anterior to SCM is what? Branchial cyst. So that A, B, C, D. Cystic hygroma is lateral to the cystic hygroma. Cystic hygroma is going lateral. That is what? Lateral. Lateral means, we say, I use the mnemonic over here, dorsal. Dorsal means lateral, right? Dorsal or lateral. I use the word at D, cystic hygroma, right? And the thyroglossal cyst, where is the thyroglossal cyst? It is present in the midline. And this thyroglossal cyst is, it moves with the what? Tongue protrusion and swallowing, so that you will understand this is what? The thyroglossal cyst. You can see over here in the picture, thyroglossal cyst, and this is a cystic hygroma, right? So you should understand their positions, okay? After we know this one, yeah, one question they can ask you here, please. I miss to explain over here. Thyroglossal cyst, the most common site is what? The subhyoid. It is below the hyoid bone, okay? So most common site is subhyoid. This is a question in the exam. Most common site for the what is this one? Thyroglossal cyst is what? Most common site is subhyoid. So please remember this one. This is a question in the exam. So now let's go to the duodenal atresia versus the pyloric stenosis, okay? So in the duodenal atresia, you have to remember best 3Ds. What are those best 3Ds? Best 3Ds means duodenal atresia. You have to remember as the, let me check my notes first. Okay, so best means what? Bilious vomiting. B-I-L-I-O-U-S, bilious vomiting, and it usually presents within 24 to 36 hours. Is that okay? Please remember this is B, right? 3Ds. D means what? It is associated with Down syndrome. Down's syndrome, right? Associated with Down syndrome. Another D is what? It shows the double bubble sign. Bubble sign. What it shows? Double bubble sign. So look at here. This is the, what is this one? Pyloric sphincter, and here is the atresia. So that this will be dilated, this will be dilated. So two bubble will be seen in the X-rays, right? So double bubble sign. So Down syndrome, double bubble sign, 2Ds. And third D is what? Distension. What is this one? Distension. Distension of duodenum and stomach, right? So these are the best 3Ds of the duodenal atresia. Remember, the question, it differs only by the time, right? And then the vomiting pattern. So look at here, bilious vomiting, because the obstruction is below the major duodenal papilla. This is our hepatopancreatic duct opening. So the obstruction is below this one, below the second part of the duodenum, right? Below the major duodenal papilla of the second part of the duodenum. So that the bilious vomiting occurs in this case, right? And usually this baby presents within 24 to 36 hours of the birth, right? So hope you understand. And what is the diagnosis? The diagnosis usually we do is what? The USG. What is this one? USG. Symptoms you understand already. What is this one? The bilious vomiting, right? And USC, that USC is antenatal. In the antenatal USC, you will see what? Double bubble sign, that I explained already. What is the double bubble sign? One bubble here, one bubble here, right? What is the treatment? The treatment is duodenostomy. What will you do? Duodenostomy, right? So this is the treatment. That means just cut and then you connect it, right? So this is the treatment. And look at here, one DD they can ask you over here. What is that DD? Double bubble sign in the antenatal USC with the absence of distal air. Absence of distal air in the intestine. That is what? Duodenal atresia. If the question is double bubble sign in the antenatal USC, but there is a presence of what? The presence of distal air in the intestine, then the answer will be what? The intestinal malrotation. Intestinal malrotation or midgut volvulus. Midgut volvulus. Hope you understand, right? Midgut volvulus. Is that okay? If there is the double bubble sign with the what is this one? The distal air in the intestines, right? So that is called, that produces what? That is the sign of what? The intestinal malrotation or the midgut volvulus. So hope you understand. This is duodenal atresia. Now let's go to the pyloric stenosis. What is pyloric stenosis? Pyloric stenosis has the thickening, abnormal thickening of the pyloric sphincter. That is circular, smooth muscle of pyloric sphincter. Its thickness increases, right? So because of this thickness increases, what happens? The lumen becomes narrower so that the food cannot pass, right? So that here in the pyloric stenosis, what you should understand is that it is the most common surgical case of the infancy. Most common surgical case of the infancy, but it is not emergency. It is not the emergency case. Please remember this one. Okay, so this is about the pyloric stenosis. First point. The second point you have to understand, yes, I already discussed. The second point is what? It is the thickening of the circular smooth muscle, and the risk factor for this one is that what? The erythromycin, the antibiotic given in the infancy. If we give this in the infancy, that produces this one. And what is the symptoms? Symptoms is, remember, non-bilious vomiting, right? And this usually occurs at the 4th week of life. That means after birth, the normal presentation time is which week? The 4th week. So remember, duodenal atresia, it appears within 24 to 36 hours. But it is appear in what? The 4th week. Another point is that duodenal atresia has the bilious vomiting, but in case of the pyloric stenosis, we have non-bilious vomiting. Please remember. And here you will see what? You will see the peristaltic movement of the stomach from left side to right side. Is that okay? Because you have the obstruction over here, and then your stomach is over here, right? So that the stomach will move from the left side to right side, but it does not empty over here, right? So that you can see the vigorous peristaltic movement from outside. You can see the olive-shaped mass from outside, right? So the diagnosis is clinical, or you can do the USG, right? So how to diagnose? USG, or clinically you can diagnose, right? And then you can see yes, one more point. What is the chemical abnormalities present in this baby? This baby will lose the HCl, this baby will lose the potassium, right? So that this baby present with what? Hypochloremic, hypokalemic, hydrogen is lost, so that the metabolic alkalosis. Do you understand? So hypochloric, hypokalemic, metabolic alkalosis is the metabolic changes within this baby's blood. So please remember this one. And so yes, diagnosis we did already. What we do the clinical diagnosis. At USC we do for the definitive diagnosis. And in the USC, what do we see is that we measure this length, this thickness, and then this channel length, right? So this thickness becomes more than 4 millimeter, and this channel becomes how much? More than 16 millimeter. Remember, these are the questions in the exam. And what is the treatment? Treatment is the Ramstedt pyloromyotomy. What is this one? Ramstedt pyloromyotomy. The process I'm not going to explain now because this is time taking, right? So we are just preparing for the exam. That's the treatment. And we can start feeding immediately after the treatment for this case. Okay. After that, these are the DDs. This which I do not explain here in the pyloric stenosis. This I'm going to explain you here in the DDs. Single bubble, double bubble, triple bubble, right? If there is a single bubble in the X-ray, we say this is what? The pyloric stenosis. Double bubble, duodenal atresia. Triple bubble, ileal atresia, or small bowel obstruction. Hope you understand, right? So this is a single bubble, double bubble, triple bubble. Single bubble is what? Pyloric stenosis. Double bubble is what? Duodenal atresia. Triple bubble is what? Ileal atresia. Questions. Remember, for example, right? Let's go to the burn, right? So let's go to burn. So in burn, some questions they can ask you in the exam, right? The most common cause of burn in children, that is scald burn. Scald means what? The liquid, hot liquid. Okay. And the most common cause of burn in the adult, adult, that is what? Flame burn. Flame burn. Remember, this is the question in the exam. And what is the Jackson model? Jackson model means, you can see over here, Jackson model explains the burn wound. What is this one? Burn wound. So in this Jackson model, you can see 3 distinct regions, right? 3 distinct regions. I want to show you something, the magical over here. What I made this one, right? You may be thinking, this is the eye I'm making, right? This eye is like this, yes or no? See this eye. So in this eye, you can see the 3 distinct regions over here. You can see number 1, number 2, number 3 zone, right? So zone 1, you can see inside, that is the zone of coagulation. Which kind of coagulation it produces? It produces the necrosis, coagulative necrosis. Here tissues are dead. No benefit of treatment. No benefit, right? No advantage. This is zone of coagulation, zone number 1. Here zone number 1. And you can see the zone number 2, right? Zone number 2 is what? Zone of stasis. What happens in the zone of stasis? You have the veins damage. You have the veins damage, right? You have the veins damage. Because of the vein damage, arterial blood comes, but the venous return does not occur. So that there will be stasis occurs. Stasis. So that it produces what? Edema. So this is also called the zone of edema. And this zone is very much vulnerable. The most vulnerable zone. But this zone also has the maximum benefit if you treat on time. Maximum benefit if you treat on time. So how many points I told? These are all the questions in the exam. Okay. So most benefit over here if we treat on time. If we do not treat, this will convert into this zone. If we do not treat on time, this, the zone of stasis will convert into zone of coagulation within 24 to 36 hours, and the tissue will die. After that, we go outside. That is the zone of hyperemia. Zone of hyperemia means it is outside where there is the venular dilation, not damage, venular dilation, arteriolar dilation. So that what happens? This region looks red. It does not need any treatment. It can heal automatically by itself, right? So here we have the uninjured tissues present over there, right? So hope you understand. So it heals without the scars. So this is called Jackson model, and it looks like an eye, right? So that this is also called the bull's eye. What do we call this one? Bull's eye. Hope you understand, right? So these are the 3 zones. Now let's go to the TVSA. the total burn surface area calculations, right? So in this total burn surface area calculations, we use different rules. Like in the adult, we use the Wallace rule of 9. In the children, we use the lawn border chart. In the, if it is the irregular and small surface area burn, we use the palm plus fingers. That is equal to 1%. Hope you understand, right? After this, what is the adult, the calculations? We use the Wallace rule of 9. So what are those Wallace rule of 9? This is the question in the exam they will ask you. Remember this neck, front and back 1% plus 1%. This head and face, front and back 7%. So this total, it makes the 9%, right? So this hand, front and back 4.5 plus 4.5 is equal to 9%. This hand also 4.5 front plus 4.5 back is equal to 9%. Remember, these are the questions in the exam. They will ask you, the patient comes to you with this area burn, right? So if this area is burned, how much percentage burn, right? So this is, so you have to understand how to calculate. And this chest, front 9%, back 9%. And abdomen, front 9%, back 9%. Remember, this leg, front 9%, back 9%, right? This leg, front 9%, back 9%, right? So see, remember, hand front and back 9%, but leg front 9, back 9. Remember this one. And the groin 1%. These are the questions they will ask you in the exam, right? So groin 1%, neck 1% front, 1% back, so it is 2%. This is 7% front and back. And this hand, front I have 4.5, back I have 4.5. This also the same. This chest I have this 7%, backside chest 9%, backside chest 9%. Abdomen front 9%, abdomen back 9%. So that this whole trunk is 18%, backside trunk is 18%. So this total is 36%. Yes, and the leg, my front 9%, back 9%. So total one leg is 18%, right? So remember, this is what the Wallace rule of 9. And in the children, we use the lawn border chart. In the lawn border chart, look at over here. Similar, like the head in the adult was 9%, but in the head in the children is how much? 18%. So this is different. Head in the children is 18%. And this keeps decreasing until it becomes 9%. Remember, right? This keep decreasing until it becomes 9. Rest of all the body parts, they remain the same, except the leg. Leg is 14%. We had the 18% front and back total, but they have 14% front and back. So that this leg, they have the 14%. It will keep increasing until it becomes 18%. So remember, in the children, the head is greater than the adult and it keeps decreasing when the age increases. Legs has the percentage less than the adult, so it keeps increasing with the age, right? Head keep decreasing, legs keep increasing. Rest of other body parts, they remain constant. Remember, this is the differences, right? Another point, we have the palm and finger, we said 1% already, right? Another point, the foot, it measures about 3%, and 3.5%, and this foot percentage 3.5% remain constant. It does not change. Hope you understand, right? It does not change in the adult or in the the children. It always remain the constant. So remember, these are the percentage calculations. They will ask you question from this percentage. And look at here the severity classifications they can ask you in the exam. Children and elderly, if it is less than 5% TBSA, we say this is mild burn and we manage this patient in the OPD, right? And if it's the full thickness burn, less than 2%, is also mild burn. If it is moderate in children and elderly, 5 to 10%, this is the moderate. We admit the patient and we manage in IPD. If it is more than 10% in children or more than 10% in the elderly, we refer this patient to the burn unit. This is a question in the exam. What are the indications for the patient referral to the burn unit? Do not manage in the other hospitals, general hospitals. Refer to the special burn hospital. Is that okay? So these are the indications. And if it is adult less than 10% TBSA, then we can manage in the OPD. If 10 to 20% manage in the IPD, more than 20% refer this patient to the burn center, right? So because it produces more complications. And what are the other indications that we have to refer the patient to the burn center? This is few points: more than 10% in the children, or more than 10% in the elderly, more than 20% in the adult, or more than 5% deep burn, then we have to refer the patient to the burn center. So please remember this one. Other indications are what? High voltage electricity burn, right? Or if there is a chances of contracture, major joint burn, right? Or around the vital organs, right? Eyes burn, right? Or patient has the inhalational burn sign. So question in the exam: what are the signs of inhalational burn? Patient may have the sign nasal hair, burn around the eyebrows, right? We can see the hyperemia inside, right? We can see the charcoal or maybe the carbonaceous, the black deposits. If these things are seen over there, then this is the sign of what? The inhalational burn. In this case, we have to refer the patient to the burn center. So please remember this one. And if the patient has the inhalational burn, then the immediate, the investigation of choice is what? You have to do the bronchoscopy, right? And then the immediate treatment you have to do, the procedure we have to do is what? The intubations to these patients, right? So please remember these questions in the exam. After that, in the burn, we go to the fluid management in the burn. So the most commonly used formula is what? The Park-Lane formula. In the Park-Lane formula, we use 4 ml multiplied by total burn surface area percentage multiplied by weight in kg, right? So this is the Park-Lane formula, most commonly used formula. Question they will ask you: the most commonly used formula for the fluid resuscitation in the burn patient is what? Park-Lane formula. And what's the formula? 4 ml multiplied by total burn surface area percentage multiplied by body weight, right? And how much will be the total amount of the fluid comes? This total amount of the fluid, the half given 8 hours and the half given next 16 hours. Please remember, right? And then fluid of choice is Ringer's lactate for the adult, and avoid the colloid formula or protein for at least 12 hours. Don't use colloid for at least 12 hours. The reason is there that we will discuss in burn, right? So this is not the proper class of burn. Fluid of choice in the children is we use the dextrose and normal saline in the children, because the children, less than 5 years, they are higher chances of undergoing the hypoglycemia, so that we have to add the dextrose in their fluid. And fluid of choice in the burn shock is what? The burn shock. Then we use the hypertonic saline. Sometimes it escapes from the mind, And most common colloid based formula is what? The Moore and Barclay, BARCLAY, Barclay formula. This is the most common colloid based formula. If we have to use some centers, they have the colloid based formula also, but we avoid colloid based because during the early hour the vessels are more porous, and colloids, they may escape out from the vessels, and they produces the more edema, and the hypovolemia may induce in the patients, right? The vascular hypovolemia may occur, so that we avoid this one. Now let's see, what is the most common cause of death at the site of burn, right? That is what? Burn asphyxia. What is this one? Asphyxia. This is a question in the exam. And most common cause of death in the burns, right? If they ask you this broad question, then this is what? Septicemia. Because of the burn, the most common cause of death is what? Septicemia. Most common cause of early death in the patient, that is what? Hypovolemia. So that fluid management is crucial. This is question in the exam, right? So please remember, most common cause of late death in the patient, that is what? The septicemia. Again, septicemia means, that, right? And most common organism responsible for the sepsis or septicemia in the burn, that is what? Pseudomonas. So please remember, these are the questions in the exam. Okay. Renal and uretary calculi. Let's go to the calculi now. Okay. So in this renal and uretary calculi, 90% of the renal calculi are radio opaque, but 90% of the the GB calculi are radiolucent. So remember this 90 rule of 90. Most common renal stone is calcium oxalate. Calcium oxalate, right? And most common radiolucent stone, that is the uric acid stone. What is this one? Uric acid stone. Please remember, question in the exam. uric acid stone, and it forms in the acidic urine. That means low pH. It forms in the acidic urine. Some of the examples of the stone form in the acidic urine are CCU. That means what? Calcium oxalate, cysteine, and uric acid. That is calcium oxalate, cysteine, and uric acid, right? So these are the stones they form in the low pH acidic urine. CCU, remember this one. This is a question in the exam. CCU, acidic urine stones. And this, what is this one? The uric acid stone is a radiolucent, most common radiolucent stone. We have some more radiolucent stones, that is TIXU. What is TIXU? That is triamterene, indinavir, and you have the xanthine and uric acid. Xanthine and uric acid. You can remember as these are the medicines, yes or no? So the the medicine induced stones are radiolucent stones. So remember, so few points we said over here. Most common radiolucent stone is what? Uric acid stone, and it forms in the acidic pH. So we have 3 stones which forms in the acidic pH. That is what? CCU. That is calcium oxalate, cysteine, and uric acid stones. And we have TIXU as the radiolucent stones. TIXU means triamterene, indinavir, xanthine, and uric acid. Okay, so remember this one. And we have the struvite stone. Struvite stone means sometimes we have the this big stone formation over here within the whole, the renal pelvis. It covers the whole renal pelvis. Much bigger stone forms, right? Struvite stone. So it is also called the triple phosphate stone. What is this called? Triple phosphate stone. What are those triple phosphate? These triple phosphates are CAM. What are those? CAM. CAM means calcium phosphate, ammonium phosphate, and then the magnesium phosphate. What is this one? Magnesium phosphate. So that we say triple phosphate stones or struvite stone. This is sometimes also called the infectious stone. What do we call this one? Infectious stone. It is also called what? Infectious stone. That means this patient usually has the infection with the protease infections, and it makes the urine alkaline, so that this is a stone formed in the alkaline urine, right? So this is the stone formed in the alkaline urine. Sometimes it is also called the staghorn calculi because it looks like the multiple branches, like so horn like, so that we call this was it, the staghorn calculi. And this stone, for the treatment it needs the PCNL and ESWL. What is the treatment? PCNL plus ESWL. So please remember few points I said over here in this struvite stone. So it's the large stone formed within the renal pelvis. It's a triple phosphate stone. What is this one? CAM. Ca means calcium, A means ammonium, M means magnesium, right? So sometimes it is also called the infectious stone because it forms at the forms because of the frequent infection by the protease, right? And this protease makes the urine alkaline. So this is also called the alkaline stone. And for the treatment we need the PCNL with ESWL, right? So two the strategy or two methodology we use. Cysteine stone is the hardest stone, and this is resistant to ESWL. ESWL cannot break this stone. This is also the question in the exam, right? So hope you understand. Now let's go to the symptoms of the renal calculi. Most common symptom of renal calculi is pain. What is this one? Pain. It's a colicky pain. And the stone in the upper ureter or renal pelvis. If the stone is present over here, stone present over here, or the stone present over here, the pain goes to different places. If the stone present within this region, number 1, number 2, number 3, right? If the stone present within this region, that means the renal pelvis or this one, it goes to testis or labia majora in the female, right? If the stone is present within the mid ureter, then if it is in the mid ureter, it goes to the iliac fossa, and it mimic the appendicitis, right? Remember, it is middle, it lies within the iliac fossa, that's why it goes to iliac fossa. Remember like this. And then the stent in the lower, the lower ureter, if it is present within the lower ureter, the pain, it goes to the scrotum, or the medial thigh or middle thigh, thigh, right? So these are the sites of the radiation of the pain. So please remember, or it may go to the perineum as well, the pain, perineum, right? And what are the investigation of choice for the the renal system? Let's see. Most sensitive investigation for renal or uretary calculi is non-contrast CT. Non-contrast CT scan. So remember this one. And retrograde pyelogram we will do sometimes if the lower ureter is not visible. Lower ureter if not visible in the non-contrast CT, then we go with what? Retrograde pyelogram. Why we use non-contrast CT? Because we are involving the renal system. Renal system has the disease, so it cannot filter the the contrast media. That's why we do not use. DMSA scan we use for the renal morphology. Renal morphology, or if there is a scar formation, then we do this one, what? DMSA. DTPA for perfusion function. DTPA for perfusion function. And MAG3, it is best for perfusion. Best for perfusion function assessment. Perfusion function assessment, right? So these are the questions in the exam, please remember. So investigation of choice for the renal or uretary calculi is what? Non-contrast CT scan, we can do it, right? So this is the investigation of choice. And retrograde pyelogram, if in the non-contrast CT, if we cannot see the lower ureter, then we do this one. DMSA scan we do for the renal morphology. If there is any scar formation over there, renal injury is over there, we do this one. If it is the DTPA, we do what? The perfusion function test we do by DTPA. But MAG3 is the best for the perfusion function assessment, right? So we do understand this one. Now let's go to the renal, management of the renal stone. Conservative management we do for 4 to 6 weeks, and this conservative management, what are the indications for the conservative management? If there is a single stone and it is less or equal to 5 millimeter. Another point, stone in the lower ureter, then we can do the conservative management. Ureter is undilated. If the ureter is undilated, that means if there is no hydroureter, that means there is no blockage of the urine, then we can go for this one. Another one, we can see the evidence of downfalling of the stone, then we can do what? The conservative management. Remember, these are the questions in the exam. And initial approach we do for 80 to 85% of the stone can be treated with ESWL if the stone is less or equal to 2 centimeter size, right? Usually we do what? ESWL for the stone size less or equal to 2 centimeter. Then 80 to 85% of the stone can be treated with the ESWL, right? Procedure. And sometimes we also use the PCNL. According to the the surgeon, they choose either PCNL or ESWL. Among these two, if they ask you which is the first or best choice, then please choose the PCNL. Is that okay? Please remember this one. And some of the stones which are the harder stone for the ESWL, right? Those stones which are hard for the ESWL, they are the brucite stone, hydroxyapatite stone, brucite, hydroxyapatite, and cystine, and calcium oxalate monohydrate, right? So these kind of stones, they are the harder stone for the ESWL, so they cannot be broken down by the ESWL, and we have to choose for what? PCNL, right? And PCNL we can use for the stone which is more than 2 centimeter size. We use PCNL. PCNL and ESWL we choose for stagon calculi. So please remember, for almost all the cases which are less or equal to 2 centimeter, we use what? ESWL procedure. And some surgeon they may choose PCNL. Hard stone for ESWL we use what? The PCNL, and these stones are brucite, hydroxyapatite, cystine, and calcium oxalate monohydrate. If the size is more than 2 centimeter, we use the PCNL. If it is stagon calculi, you use the PCNL and ESWL together. And let's go to the uretary calculi management. If it is the proximal and mid ureter stone, right, less than 1 centimeter or more than 1 centimeter. If it is less or equal to 1 centimeter, we do the ESWL, right? If it is more 1 centimeter, then ureteroscopy, right? We just pass the tube and then we just extract the stone in the basket. Distal ureter stone, if it is less than 1 centimeter or more than 1 centimeter, for both the cases we use the ureteroscopy. Ureteroscopy, here also ureteroscopy. Remember, in this case, in the ureteric stone, only upper third, right, or the middle third, and size is less or equal to 1 centimeter, then only we use ESWL. Rest of other cases, always we use what? Ureteroscopy. Ureteroscopy. Hope you understand, right? Let's go to the gallbladder and cholelithiasis. You can see the vulva fester. What is the vulva fester? Vulva fester is this one. In the cystic duct, you have the mucosal folding. The mucosal folding within the cystic duct, that is called what? Vulva fester. Mucosa of cystic duct, that is called what? The vulva fester. Sphincter of OD means here you have the sphincter of OD. It has the 3 components. How many components? 3 components. What are those 3 components? One component is present over the bile duct, one component present over the pancreatic duct, right? And then you have the another component present as the ampulla over here. Okay, combined, right? So that the 3 component of the sphincter of OD, that is what? Sphincter cholecocus, sphincter pancreaticus, and sphincter what is this one? The ampulla, sphincter ampulla. So what is this one? Sphincter cholecocus, sphincter pancreaticus, and sphincter ampulla. So there are 3 components they can ask in the exam. This is the here, right? And callus triangle. What is the callus triangle? Callus triangle means, you can see over here, this is the callus triangle. You have the border of the liver, you have the cystic duct and the gallbladder, and then you have the common hepatic duct. So this is a callus triangle. What is the content of the callus triangle? This is a question in the exam. Content is what? The cystic artery. So this is most vulnerable during cholecystectomy. It can be injured. So remember, callus triangle, what are the boundaries? We have the boundaries medially common hepatic duct, laterally cystic duct with the gallbladder, and superiorly we have the inferior border of the liver. So please remember this one, right? So this is the superior border, and this is the lateral border, and this is my what? The medial border. So in the medial border, what do I have? Common hepatic duct. Superiorly, what do I have? This is the inferior border of liver. Laterally, what do I have? The cystic duct, and the gallbladder, right? So this you have to remember. Another point, the Hartmann's pouch. Hartmann's pouch is the pouch over here within the what is this one? The Hartmann's pouch, right? It is present within the infundibulum of the gallbladder, and then this is the most common site for the stone impaction. Right? And if the stone is present over here, it may compress the cystic duct. If it compresses the cystic duct, then bilirubin and then the bile juice cannot drain down, so that it produces the obstructive jaundice, right? Obstructive jaundice. Hope you understand. This is called the Meiji syndrome. What is this called? Meiji syndrome. So what is the Meiji syndrome? It is the the obstruction of the common hepatic duct because of the stone present within the which part? Present in the Hartmann's pouch of the gallbladder. Hope you understand this one, right? Cholelithiasis. What is cholelithiasis? Cholelithiasis means the formation of the gallstones. And how is it formed? It has a 3 mechanism. That is what? Lithogenic bile. Lithogenic bile. Lithogenic bile means cholesterol concentration increase in the bile. That is lithogenic bile. Another one is the nucleation. Nucleation means what? The cholesterol monohydrate crystal should be formed. What should it be formed? The cholesterol monohydrate crystal should be formed, and there should be the stasis. Stasis. Nucleation means cholesterol monohydrate crystal, right? Formed because of the lithogenic bile, there is the collection of the cholesterol and it forms the cholesterol monohydrate crystal with the calcium. And there is a stasis of the bile. Stasis of the bile means if maybe our GB gallbladder is not contracting well, right? So if the GB is not contracting, then the the bile juice cholesterol remain longer within the gallbladder. Because of the presence of this longer stasis, it produces the nucleation, right? So that it produces the stones. And what are the type of the gallstones? We have different types of stones over here, right? So most common type is the mixed cholesterol stone. Mixed cholesterol stone, and you can see the mixed cholesterol stone over here, right? The color of the mixed cholesterol stone about 70%, right? And black pigment stone is due to the chronic hemolysis. Those patients who has the chronic hemolysis, for example heart valve, they have the prosthetic valve over there. This prosthetic valve causes the continuous breakdown of the RBCs, right? Or somebody has the congenital the hemolytic disease, so this patient produces the black pigment stones. And this black pigment stones, it contains what? Calcium bilirubinate or mucin. It contains what? Calcium bilirubinate. So please remember, because of this the hemolysis, it produces the black pigment stone. And brown pigment stone, it is produces in the patients with the infections, frequent infections of the gallbladder, frequent infectious gallbladder, it produces the brown pigment stone. It contains the calcium salt of unconjugated bilirubin. Calcium salt of unconjugated bilirubin. Those patients who has the liver disease, right? So they are producing this one. And what are the presentations of the cholelithiasis? It may be cholecystitis, infections, right? Inflammations, maybe mucosily, it may be cholecystoenteric fistula, maybe acute pancreatitis. So remember, cholecystitis, we'll discuss some point over there. Cholecystoenteric fistula, that means the fistula formation between the gallbladder and then the duodenum, okay? Most common site is the second part of the duodenum. It forms the fistula over here, so that the stone may passes down, and this stone may go to the distal ileum. Go to what? Distal ileum. Most common site of the obstruction by the stone. Distal ileum, that means we can say the 60 centimeter proximal to the ileocecal valve. Ileocecal valve. So please remember this one. And it obstruction produces the gallstone ileus. Gallstone ileus. So they can ask you in the exam, most common site of the gallstone ileus. So this is the site, right? So it produces this one. And acute pancreatitis. So acute pancreatitis, most common cause is the gallstone. Most common cause for the acute pancreatitis is the gallstone, and the second most common the chronic pancreatitis, most common cause is what? The alcohol. So the most common cause for acute pancreatitis is gallstone. They can ask in the exam. And look at here, the cholecystitis, that means the patient has the inflammation. The most common cause of acute cholecystitis, that is the cholelithiasis. That is cholelithiasis. That means the stone in the gallbladder. Please remember this question in the exam. And triad of the acute the cholecystitis, that is the patient may have the right upper quadrant pain, right? The triad of the acute cholecystitis, please remember this one, question in the exam, right? So right upper quadrant pain, RUQ pain, this is the most common symptom in the exam, right? They can ask you. And patient has the fever, plus patient has the increased WPC, that is leukocytosis. Okay, so please remember. And the patient has the Murphy sign positive. This is patient is assessing Murphy sign, and this is also called the Nonnie's sign, right? And Boas sign also positive. That means the hyperesthesia in the inferior to the scapula will be there. And diagnosis for the cholecystitis is USG or HIDA scan is the gold standard. HIDA scan is the gold standard, but commonly we use the USC, right? And what is the treatment? Treatment is we can do the early cholecystectomy within 2 to 3 days, right? Or sometimes we can also do the delayed cholecystectomy that we do usually in 6 to 10 weeks later after the medications. Indication of cholecystectomy, please remember, gallstone if it is more than 3 centimeter, multiple stones over there, stone with polyp, and porcelain gallbladder. Porcelain gallbladder means calcification and thickening of the gallbladder. And gallstone with diabetes, because it produces the emphysematous cholecystitis that produces the peritonitis. 90s. Okay, so please remember this one. And stone with polyp is indication, and without stone, if the polyp size is more than 10 millimeter, that is also the indication for the cholecystectomy. And let's see the most common benign tumor of the gallbladder, that is what? Adenoma, right? And most common malignant tumor of the gallbladder, that is what? The adenocarcinoma. What is this one? Adenocarcinoma. They can ask you in the exam. And what is the Charcot stride of the cholangitis? That is fever plus pain, maybe in the epigastric pain, and plus patient has the jaundice. That is what? The Charcot stride. And treatment of choice is ERCP plus sphincterotomy. Sphincterotomy. That means you have to cut the sphincter of OD, right? And this cutting should be always in the 11 o'clock position. This is question in the exam, okay? Because to avoid the injury to the it avoids the injury to the exact the sphincters. This one we did. And now let's go to the hernia. Most common type of hernia in male and female is what? Inguinal hernia. That is inguinal hernia. Please remember, this is the question in the exam, inguinal hernia. And this inguinal is also most common is indirect inguinal hernia. And parts of the hernias covering sac and content will be there. So please remember types on the basis of the content. Okay, so this is the question they will ask in the exam. What is the Richter hernia, right? Richter hernia means it contains the intestine circumference. It produces the strangulation but not the obstruction. Of the intestine. And another one is what? The Litter's hernia. Litter's hernia means it contains the mucus diverticulum. And another one is the Maillard's hernia, right? So Maillard's hernia means it contains the two loop of the intestine. And it looks like a W, right? So this is the Maillard's hernia. And Spigelian hernia means the para umbilical hernia. This hernia is present below the umbilicus, and between the or lateral to the margin of the rectus abdominis muscle, right? We can see the lateral to the semilunar line. So this is the questions. And let's see over here the inguinal versus femoral hernia. This is inguinal hernia, this is femoral hernia. So what are the differences? Inguinal hernia above the inguinal ligament, femoral hernia below the inguinal ligament. And inguinal hernia we have medial to the pubic tubercle. Here we have the pubic tubercle. And the femoral hernia is lateral to the pubic tubercle. So please remember these are the differences, okay? Yes, above and medial to pubic tubercle is this one, and below and lateral to pubic tubercle is femoral hernia. So please remember this one, okay? And it is below the inguinal ligament, above the inguinal ligament. The differences you understand, right? And femoral hernia most commonly undergoes the strangulation. Inguinal hernia less commonly goes for the strangulations, okay? And femoral hernia is common in female, more in female than in male, right? So please remember this one. And another point, femoral hernia, sometimes we can approach the repair from here, we can approach the repair from here, we can approach the repair from here. If we approach the repair from here downwards, right? So that means this is called the Lockwood. What is this one? Lockwood operation. Sometimes we approach from here. That means the inguinal region. That is called what? The Lothatian. That is called Lothatian operation. And sometimes we approach from here. That means the above this one. That means the high inguinal region. That is called McAvedy repair. McAvedy repair. I'm doing very fast because it becomes very long, so people may become bored, right? So let's see over here direct versus indirect inguinal hernia. This is the Hasselbeck triangle. What is this called? Hasselbeck triangle. So the Hasselbeck triangle is bounded by, this is a question in the exam, medially the lateral border of the rectus abdominis muscle. You have laterally the inferior epigastric vessel, and inferiorly you have the inguinal ligament, right? So this is the inguinal ligament inferiorly. Laterally you have the inferior epigastric vessel, and medially you have the lateral border of the rectus abdominis muscle. So remember, from the the Hasselbalch triangle we have the direct hernia from the Hasselbalch triangle. Okay, and outside the Hasselbalch triangle, from here we have a direct hernia, right? Hasselbalch triangle. Another point, direct inguinal. This is direct, this is indirect. Okay, so this is direct, so it is coming from the Hasselbalch triangle. And another point, it is coming from the posterior wall of inguinal canal, right? The posterior wall of the inguinal canal. It comes in the older individual who has the weak musculature, weak muscle, right? We have the weak muscle. Another point, it is large. The sac is large and it is reducible. It is large, so it does not reach to the scrotum. No reach to the scrotum. Is that okay? And less chance of strangulation and obstruction. Okay, this is the direct inguinal hernia. Indirect is coming from the deep inguinal ring. It is outside the Hasselbalch triangle, right? Outside the Hasselbalch triangle means it's lateral to inferior epigastric vessel. Remember, this is question in the exam. Okay, and this is smaller in size, but it is non-reducible or hard to reduce. It reaches to the scrotum. Another point is that strangulation, higher chances. So please remember, these are the differences between these two. They will ask you in the exam. And what is this one? Hernia treatment. Most common primary tissue repair is what? The soleus repair. Remember over there. And omphalocele and gastroschisis you can see over here. Omphalocele is this one. Gastroschisis is this one. Omphalocele coming from the umbilicus, and it is because of the rotation failure during the embryology, right? So rotation failure, and it has the amniotic sac covering. It has the amniotic sac and peritoneal covering over there. And gastroschisis, it is para-umbilical, not the umbilical, para-umbilical, and commonly on the left side, okay? And it has no coverings. It is more, the chances, fatality is more in case of gastroschisis because of the dehydration, because there is no covering, right? And congenital diaphragmatic hernia, you just see this. There are two types of congenital diaphragmatic hernia. You go and see by yourself, okay? And let's see over here the abdominal trauma. Very fast, very quickly. It becomes very long, right? So abdominal trauma, let's see. Most common blunt trauma, then that is what? The spleen. Most common blunt trauma, it injures the spleen. Most common penetrating trauma, liver injury. Most common injury by gunshot, that is small intestine. Most common injured bowel in blunt trauma, that is jejunum. Most common injured site in deceleration injury. Most common deceleration injury is duodenojejunal junction. Right. First investigation done in blunt trauma abdomen. That is what? FAST scan. FAST. That means focused assessment with sonography in trauma. Focused assessment with sonography in trauma. Sometimes ask you in exam, right? And we will evaluate 4 P's. What is that 4 P's? 4 P's means pericardial sac. After that we see the perihepatic region. That means heart, liver, and perisplenic region, spleen, perisplenic region, and then we go for the pelvis, right? So we assess 4 P's in first scan. They will ask in the exam. Gold standard investigation in stable patient of blunt trauma abdomen, that is CT scan. We have to go for what? CECT, contrast enhanced CT scan. Most common seatbelt injury, that is mesentery. Most common blast injury, if there is a blast, then that is tympanic membrane. Blast injury is tympanic membrane. Then it goes to the lungs, right? And there is the most common underwater blast injury. If there is the underwater blast, then it is GI tract, that is stomach. Okay. And 2 points over here: Cullen sign and Gray Turner sign if there is a splenic injury, or we have the pancreatitis. It produces the ecchymosis. Look at here. So it goes to the umbilicus. Umbilicus is C-shaped, so this is a Cullen sign. And another one, it goes to the flank. This flank sign is what? Gray Turner. So Gray Turner is flank. Cullen is what? Around the umbilicus, that is ecchymosis. So umbilicus is C-shaped. That's why we say this is Cullen sign. Remember this one. Let's see the intracranial hematoma, that is epidural, subdural, and subarachnoid. Epidural hematoma, most common bleeding artery is middle meningeal artery. What is this one? Middle meningeal artery, right? Middle meningeal artery, and this is because of the fall. Okay. And if this is epidural hematoma, you can see it produces the, what is this one? This is a what is this one? Convex shape, right? It produces the convex shaped hematoma because it does not cross the suture line, right? So please remember, or convex shape or lenticular shape also we say lenticular shape, and it compresses the brain more. See, so it is more dangerous. We need immediate evacuation. So this is question in the exam. They will give you like this, okay? Question in the exam. Similarly, subdural hematoma. Subdural hematoma, the most common bleeding vessel is bridging vessels. Bridging vessels. So they produces what? They produces long, you can see over here, this much big hematoma, right? This much big hematoma. So this is what? This is called crescentric shape. What is this called? Crescentric. C-R-E-S-C-E-N-T-R-I-C. Crescentric shape hematoma, right? So this crescentric shape hematoma, this is less dangerous than epidural hematoma, of course, because it is not compressing the brain at one point, right? So this is subdural hematoma. And subarachnoid hemorrhage, sometimes we have the berry aneurysm rupture. So it produces the hemorrhage within the subarachnoid space, and then you can see this kind of, the mixture of blood within the, the cerebrospinal fluid, right? So these are the, and these patients, they comes to you with the chronic headache sometimes, subdural hematoma patients. What is this one? Subarachnoid hematoma patients. And these are the GCS. Please calculate the GCS. We have the GCS has the 3 components, right? So you have to know these 3 components: the verbal, eye opening, and the motor response. So remember these, the total, the maximum score for the GCS is how much? 15, and minimum score is 3. So please remember, if it is the mild head injury, the score is 13 to 15, right? And if it is the, the moderate head injury, then we say the score is how much? 3 to 12. And if it is severe head injury, less than 8, right? 8 or less than 8, okay? 9 to 12, sorry, I wrote 3 to 12, right? So if the patient has the GCS score less or equal to 8, then we go for what? Intubation, right? So these are the indications. So remember, these are the questions in the exam, okay? They will give you the head injury patients and their characteristics. You have to know how to calculate the GCS. After that, needle thoracocentesis, sometimes we do in the second intercostal space, sometimes we do in the fifth intercostal space. Second intercostal space, mid-clavicular line. Please remember, question in the exam. Fifth intercostal space, we choose the anterior axillary line. Sometimes we do the diagnostic thoracocentesis. In the diagnostic thoracocentesis, we keep the patient like this, leaning forward, and then we choose the space where 1 to 2 intercostal space below upper level of the pleural fluid in mid-scapular line, 5 to 10 centimeter lateral to the spine. So remember, this is also the question exam. And intercostal drain, sometimes we put in the triangle of safety. In the triangle of safety, you should remember what are the boundaries of triangle of safety. This is our pectoralis major muscle. This side we have latissimus dorsi, and then here we have the serratus anterior muscle, right? So this is the triangle of safety. So we insert the needle from the triangle of safety. This is for the intercostal drain. So remember, this is question in the exam. So I think we did very fast. Hope you understand. This is only the overview. These are the overview of the topics. Please go through those topics. Probably you get maximum questions in this exam from this topic. So this is my good wishes to you all for your upcoming the FMGE exam. So our video become too long. Please don't get bored and try to go through this. We just try to make some overview only. Of course, this is not the complete curriculum. Okay, so my advice is please go through this lecture. After this, if you have time, go through these topics once, and then get inside your surgery exam. Wish you good luck all the upcoming FMGE exam, the students who are going to give you exam. Thank you very much. See you again.